So we know that we are able nowadays to correct astigmatism. So can you make a comment about the interest of combining toric lenses to all this profile, and what are the thresholds for you for indications if we think about EDOF and trifocal, for instance?
No, I think for astigmatism in presbyopia lenses, we really know that you have to target for a low amount of residual astigmatism. So 1 diopter or 1.25 diopters of residual astigmatism, that's really not acceptable. That's not going to work. We know that from the work from Hayashi, what has been published years ago already. So I think you have to use a toric version, or in some instances probably you can combine it with relaxing incisions, although they are less predictable, of course. But my preference really is going for toric IOL in those cases where you have well, depending on the axis that you do the surgery, of course, where the steep axis is, but 1 diopter, 1.25 diopters of astigmatism, you need to use a toric IOL.
I just reviewed my data. In a case of 3,000 femtosecond laser cases where potentially you have presbyopia-correcting IOLs, we had 60%, 65% of presbyopia-correcting. That's a high number. And the other 35 was basically monofocal lenses. In the monofocal lens, we had aspheric lenses, and a third, so aspheric and aspheric toric, a third of them were toric. And if you look at the presbyopia correcting, same thing. We had presbyopia, 66%, and the other 33% were toric presbyopia correcting. That means we're correcting really down, as Rudy pointed out, below 1 diopter, or basically below 0.75, 0.5 is even better, because particularly in the presbyopia correcting IOL, you have to do it, because the focus on the retina have to be, spot on. And if you have residual astigmatism, it doesn't work. That was 20 years ago. The big problem of multifocal lenses that they had no toricity, they couldn't correct this, they had so much variation in calculation that it doesn't work.
We know your expertise, Oliver, in the field of calculation. What is the place nowadays, especially talking about the small amount of astigmatism of the posterior astigmatism, and what is the level of accuracy that we can expect? Maybe some tricks, but I think formula?
Absolutely. I think the less the astigmatism, the more difficult it is to assess. If we have a patient with 3 diopters with astigmatism, no matter which technique we use, a keratometry, a topography, a tomography, will have a very similar result. They will be usually very, very similar, and also to the glasses the patient has. When we come down to 1 diopter, 0.75, and we take these different techniques of measurement, they're all over the place sometimes, not always, luckily. And I think that's really an important issue, and especially that's where dry eye plays in. If the patient has a dry eye on top of that, every time he blinks, you have a slightly different measurement. So I think what you need to do in these patients is you need to make a series of measurements with different machines, which we do for all toric lenses, but here especially with the lower astigmatism. And then you need to compare them. And if they don't compare well, then you probably have to try to find the reason and have to look at irregular astigmatism, dry eye. If it's dry eye, you have to treat the dry eye, redo the measurements, and hope that you get better measurements. And if you don't get good measurements, just leave it. Don't do it. And then these are probably not good candidates for presbyopia correcting lenses anyhow. Yeah. So I think you have to be meticulous, and then the formulae, there's several out there, and the modern ones, they all work quite well. But really, the measurements, I think, is a critical point from my perspective.
But that's only the measurements, because after that you have the surgically induced astigmatism that can vary.
What about the rotation, by the way, Rudy?
You have the rotation, you have the alignment on the axis.
That adds on.
That adds on. And well, we know that you only can achieve a certain amount of accuracy in alignment, which is around 3 degrees. Better is not possible, whatever you're doing, whether it's digital or whether it is manual marking. So there will be certain limitation. Now, in the low levels of toricity, that's probably not that big a problem, actually, if there is a 3 degrees misalignment. But in the higher levels of astigmatism,
of course,
then it is certainly a big difference.
Let me add to Oliver's point. For those who are going to start these lenses and would like to use them, you have to be willing, when you start using these things, you have to be really ready for taking all these preoperative measurements. You have to take the time. It's not like you go in a cataract, take it out, do the lens, and no. You have to take time. It's preoperative measurements. It's the talking to the patient. It's time consuming, but it's worthwhile doing it, because your outcome first of all, they get better, and the patients will be more satisfied. But you have to be ready to do that.
You were mentioning previously a huge series of flags that you can use, of course, in this kind of premium surgeries. Is there a place for relaxing incision based on the laser when we are talking about the correction of this very small amount of astigmatism compared to a toric lenses? I mean, is there a debate around that?
Yeah, that's a very good question. If you look at because we reviewed 3,000 eyes, so the first 10,000 were maybe 10% relaxing incision, and then we went a little bit down to 8 to 5. And the reason is that we use more toric lenses, like Rudy pointed out, more toric, but we still use them. And of course, it also comes back to the point Oliver made. The measurements have to be even better, and then we can even go to smaller amounts. So I think that combination of the toric version with a little bit of basically limbal relaxing or basically as laser keratotomies can be very effective, but we have to learn more about it, really about our nomograms and how to combine it. But this all can add up to a very nice surgery.
You know, I have not seen a very well-designed study on this yet, actually, but we've done a comparison study, and that was not only focused on the low degrees, you know, it was up to 1.5 diopters actually, so not only 0.75 and 1. But my impression from that comparison was clearly that toric IOLs do better than even than the awkward keratotomies made by the laser. Yeah. And we know from the past, you know, that if you do it manually,
even in terms of stability, I guess.
Worse.
And the reason we did less, that we use more the toric version, even in the lower parts, and then only if we couldn't use this lens or it's not available in this, or we just add a little bit of astigmatic component, you know, to titrate the surgery. But I agree with Rudy. We go for toric.
You just bring another, you know, another factor into the equation if you do it in comparison to toric IOL.